Welcome everyone to this webinar with the Faculty of Clinical Informatics. We're really delighted to run this webinar today, all about data learning and development needs for occupational therapists working in social care. We had a webinar a few weeks ago also looking at people working in with digital skills in social care, and this is a really nice follow on from that. So if you came to that one as well, then welcome back. We'll be recording the session today so that we can share it with anyone who isn't able to join live. Just the usual housekeeping, if you can make sure you stay on mute, just so we don't have any background noise. If you have any questions or comments at all, pop that in the chat. Yeah, I think that's everything, and I'm delighted to hand over to Suzy to take us through the webinar today. So here's Suzy England. Thank you.
Brilliant, thank you, Lindsay. So my name is Suzy England, and I'm a professional advisor in health informatics at the Royal College of Occupational Therapists, and I'm also going to be the chair for this session. So we've got a really busy programme, and as Lindsay's already mentioned, please feel free to sort of put your questions in the chat, and we will attempt to sort of try and cover some of those at the end of the session. So yes, please use the chat box facility throughout. So without further ado, I'm going to go straight on to the survey findings. So next slide, please, Lindsay. So just in case you didn't see it sort of going around in the Twitter space, when we launched the new ARCOT data and innovation strategy, we decided to also launch a survey as well to try and help understand how confident occupational therapists feel using data at different points in their career, and particularly to look at as well whether particular context of practice, so for example, whether you were employed by the NHS or by the local authority, whether you felt more confident to use data. And also we asked occupational therapists as well to sort of give some examples of what's worked for them in terms of improving their data confidence, but also what their perceived learning and development needs are. Next slide, please, Lindsay. So we had 349 responses, so that's 1.5% of RCOT's membership. And interestingly, this session today is obviously about social care, so occupational therapists who are employed in the social care workforce. And so although it seems a low number, which is 38, it's actually 1.5% again of our membership. So that was quite interesting. But I think that you're probably immediately thinking 1.5%, that's quite a small percentage, which it is. And so really, I kind of just want to sort of, I guess, have a bit of a disclaimer that this isn't about making generalisations about the whole of the social care workforce today. But it does give us some indication of where to focus and what we need to better understand. And hopefully today is an opportunity to begin to start trying to understand that in more detail through the questions and the comments that you provide us with today. Next slide, please. So I'm going to cover sort of two main themes in this webinar, and the first theme is about how occupational therapists use systems and how confident they feel to use systems. Now, really interestingly, of all of the occupational therapy groups, so we looked at specialist sections, regions, as well as contexts of practice, and occupational therapists employed by social care were the only ones that were 100% digitalised with electronic record keeping system, which was quite an interesting finding in itself. So those main suppliers were people like Liquid Logic, Care First, Mosaic, Eclipse, but also there's also some nation-specific systems like Wickes in Wales as well. So the other thing that came through, and we've kind of known this for quite a while, is that occupational therapists are also quite heavy users of systems as well. So 36% of occupational therapists use 2 systems and 10% use 3 systems. Now, in part, this is a little bit higher than other areas of occupational therapy practice. And my suspicion in looking at the qualitative data is that's really because of some of the contracts and commissioning that happen in social care. So things like telecare, housing, home improvement agencies, managing DFGs, as well as also things like care agencies and third sector organisations. So I guess what we're really saying here, if we look at some of the feedback through the surveys, this is quite a complicated information place for occupational therapists and social care. And they use words like they have to be a detective, to try and join these systems together, and often they feel that it's out of their control to make changes to systems if it's an external or private business. And sometimes there's just different information requirements as well from those different systems. So next slide, please, Lindsay. So interestingly, 68% of respondents said that their employing organisation were not looking at linking up these systems. Yet 92% of occupational therapists in the local authority felt that they had effective mechanisms for sharing information. That's a really interesting finding, and for me, I was sort of wondering what was underneath why people felt that that was effective. Is it that sense of, it kind of works, don't touch it? Is it a really complicated? People have talked about things like having to be a detective. Why is there such sort of high confidence that it works? And so because we've got lots of systems being used, we've also got other things being used, other channels. 95% use email to share information, 92% phone, 50% post. So only 34% of people predominantly use the electronic record keeping system. And so you've got a lot of occupational therapists that are ringing to check information is received, that they can act on it. So I'd imagine really quite tiring and exhausting really for just actually carrying out the occupational therapy process. Next slide, please. So I think I've already kind of alluded to this really, but the purposes of systems is quite interesting really. And I think from the survey findings, there's two main things that came through here. So occupational therapists need to use systems to be able to carry out the workflows and processes. And I think that's the area where there's a huge challenge for occupational therapists and not an obvious place to be able to develop that. I'm going to move on to an example in a moment, but just sort of hold that, in terms of that functionality of workflows and our occupational therapy process, that is something that needs looking at. And then the other area for the purpose of a system is about information sharing. And so that is really all about the right information at the right place. And I think that that's what that 92% is all about, really, in terms of it being effective. The information does get there, but it's, it's a kind of a roundabout way, really. So I'm going to move on to an example of kind of how this really stifles innovation, really, for occupational therapists working in social care. So this example has come from a principal occupational therapist at the Nottingham County Council. So she shared her experiences of attempting to streamline the DFG process across the county. And so she recognised, and they recognised, that there was no internal method of capturing information from when a person first makes an inquiry or referral about an adaptation or housing, right through to the end in terms of what of the outcome. So she wanted to be able to gather timescale data, I guess, about how quick it is and how efficient it is. She wanted to be able to signpost people to the DFG means tester calculator. Also wants to understand the issues that people face throughout that whole process, as well as promoting the need for consistency across district partners based on postcode. Next slide, please. So the method was an East Midlands Academy leadership course. So a 100-day plan was to develop the focus on objectives and established outcomes achieved within a 3-month period. So the Principal OT and Strategic Housing Commissioner, they worked together to develop this project, with the Principal Occupational Therapist taking a lead on the task and finish work. So the outcome, rather sadly, the outcome has been halted because of the functionality of that system. So everything was in place about what needed to be done, but it was quite simply that the system couldn't receive an email from partner organisations. So that just shows, in terms of innovation and occupational therapists and local authority, how we work, the process in which we work, may need a little bit more understanding. We need to possibly be working with system providers to better understand the things that we do out in practice. Next slide, please. So putting all this together, what does improvement look like here? And how does this relate to the need for an improved digital backbone of the social care sector? So I'm going to introduce Mark in a minute, who's going to talk about the recently Adult Social Care Digital Skills Review, who's going to talk a bit more about that. But I guess it's a question just for those on the call today to think about. Does the process of occupational therapy in social care need looking at to better understand the functionality and information requirements of occupational therapists in this sector? And who should be involved? I've already alluded to system providers, but who else? And I'm sure Mark will cover this in a little while, but is this just occupational therapy specific, or are we looking at the whole of the social care workforce? So I'm going to hand over to Mark now.
Good afternoon, everyone, and thank you, Suzy. I'd like to suggest, before I even introduce myself, that the answer is yes to that final question. But just to say hello, my name is Mark Nicholls. I'm the Chief Social Worker and the Social Care Lead for NHS Digital. And I'm leading on a piece of work at the moment across the NHS in England, which is looking at professionalising the use of digital technology and data across the social care sector. So that includes OTs who are working for local authorities, social workers, nurses in social care, registered managers, and that bulk of the social care workforce that are providing hands-on care. So I just wanted to say a few things today which provide a bit of context and a bit of co-terminosity, I think, in relation to the rest of the social care sector and some of the things that Suzy's been talking about in her previous slides. Could you swap to the next slide, please, Lindsay? So to give you a bit of background, in December last year, a digital technology and skills review, an NHSX adult social care technical and digital skills review was published. And that you can find out more about that on the Ipsos Mori website. But there was quite a significant background and run up to that piece of research that took place. So within NHS Digital, we had a social care programme running for around 4 years, which set some of the foundations in place for that work. We did some work on research into information and technology in social work with Sky in 2016. And then a piece of work on digital capabilities for social workers, which Sky and BASWA published. That was in March, when would it be, 2020, the very beginning of the pandemic, probably the worst time to publish any piece of research. But you know, please check that out, because again, in relation to the research that Suzy's already done, there are quite a lot of similarities. And you know, those pieces of work and the eventual piece of work from Ipsos Mori that I mentioned at the beginning highlighted a lot of digital disparities between health and social care, meaning that it's going to be very difficult for us from a social care perspective to work very closely with our health partners, as we're expected to do in the future in the new world of ICSs. Next slide, please, Lindsay. So I'm going to skip over a lot of this, because the themes from the skills review are possibly not anything that would surprise any of us on this call. So confidence rather than skills were a barrier. There was widespread use of digital technology within the sector. Age perceived to be a factor in levels of skill. The skills required to do the current role tended to define what people learned and what they didn't, and what they were interested in and what they weren't really. There was a kind of lack of understanding of the range of technologies that were available to be able to help people to do their job and to provide services to the people who we work with. Learning development was important, but also there was a need for support. The kind of buddying schemes that we have when we introduce a new system were thought to be really valuable in helping people to get to grips with use of technology. And key, really, there was a need for improved digital leadership in social care. So who's taking responsibility for that stuff? You know, is it the director? Is it the manager? Is it somebody who's in a position of responsibility, like a principal OT? But somebody needs to be taking responsibility for that. And just finally from me, I wanted to highlight some of what we've learned over the last few years in terms of why we need to be concerned as professionals about our digital skills, about our learning and development around digital and data. So for those who are receiving social care services, the result of improved digital skills from professionals is that they will get improved care, especially as we move more towards digitally enabled care for people. Having an informed professional working with them is likely to improve the care that they receive. They're likely to benefit from a wider range of services. So, you know, rather than the kind of face-to-face services, just the face-to-face services, because there is still a place for those, let's be clear, rather than just the face-to-face services that they have been receiving, they're likely to benefit from a much wider range of different services. And of course, digital technology can help to support people's independence at home, rather than having to go into some kind of more involved aspect of care, like a residential home, for example. For those working in social care, so ourselves, digital technology can help to free up time and other resources. It can benefit from the influence and guidance from care professionals on how digital is developed. So, you know, if we're more involved in shaping the systems that Suzy was talking about, they're more likely to work for us and the people that we work with, rather than, you know, just work for feeding the beast in terms of data, for example, you know, which I know is an issue for a lot of professionals. And also, increasingly, as we move forward, having digital skills for us as professionals makes us more marketable on the job market. And for those who supply technology to social care, having digitally enabled professionals means that they've got better access to subject matter experts to help them to develop their top technology. It will lead to improved products which better meet people's needs, and it will give those suppliers a better market advantage. So I just wanted to run through some of that learning that we've got in relation to social care over the last few years. And I'll hand back to Suzy now.
Thank you, Mark. I think that's a really good way to sort of come back in, really, because I think in terms of that NHSX digital skills review, it's really interesting that there is a gap between skills and confidence. So I think that's why it's really important to try and understand how occupational therapists are using systems in the first place to better understand that gap. So the sort of second theme then that came through from the survey is exactly what the NHSX skills review came through, which is to better understand the profession's confidence with data at different points of their career. So interestingly, the survey didn't highlight any differences between contexts, which is a little bit different actually in terms of the NHSX skills review, which that says that possibly when it comes to social care, that whole digital backbone is not there, and there could be problems with the ICS. But interestingly, in terms of occupational therapists, actually, they don't necessarily feel that different in terms of their use of skills to use systems. So 60% of responses rated themselves as satisfactory or above with their data knowledge and skills. And that's quite easy to understand, I think, when you think about some of the training that occupational therapists and social care can access. So 65% say that they can access system-specific training, 50% can access record-keeping training, much lower, but still sort of relatively high, 34% can access shadowing and mentoring. What I think is worrying, and particularly for the profession of occupational therapy, is whilst we've got a relatively high confidence of using data more generally, or just a probably better way to put it, quite a high confidence of data knowledge and skills at 60%. That drops down to 15% when you ask occupational therapists, how confident do you feel to use the data you capture to evidence the impact of occupational therapy? And some of the things that were very different in terms of the social care responses was little or no use at all of occupational therapy outcome measures, and record keeping practices and data collection being more aligned with statutory duties. And so if we just move to the next slide, actually, think it's on here, a really good, yes. So there's a really great quote here, which will lead us to our next two speakers who are going to talk a lot more about social care outcomes. So one of the quotes from the social care responses was that in their experience in adult social care, occupational therapists do not use outcome measures consistently, and if they do, they're not built into the IT systems. Due to performance measures and statutory duties in adult social care, there's an over-reliance on data around Care Act assessment, support plans and reviews, so the focus on occupational therapy is lost. RCOT could help with raising the profile of occupational therapy data, working with adult social care colleagues to give them the skills and support to manage these conversations in their workplace and feel more confident, in having conversations around data and outcome measures. Now, before I move on to John Bolton, who's going to talk about social care outcomes, I think if we just reflect for a moment on some of what we've heard, if there is, I don't want to use the word pressure, but if there's only a certain amount of time, should we say, to be able to think about how we use systems, which we would hope, wouldn't it be, to support practice so that people get the service that actually helps them. And actually then there's another sort of time demand, which is to be able to report on these statutory duties. It isn't a surprise, is it, that the occupational therapists working in social care actually maybe struggle to find that time and focus to really look at capturing the impact of occupational therapy. So I'm going to hand over to John Bolton now, who's going to talk a little bit about social care outcomes.
Right, afternoon, everybody. My name is Professor John Bolton. I am a social worker by background. I had at one stage in my career been a director of social services, and the last 12 years I've been working as a visiting professor at Oxford Brookes University. I've been looking at social care and health. My current work very much is focusing on hospital discharges. I'm working with the Department of Health on their review of discharges. And what I wanted to try and introduce into this conversation is actually what is the role of the occupational therapist in the local authority? And have local authorities rather misused or not understood actually the scope and range that occupational therapists have? In fact, in that last slide, we saw that therapists were saying there's an over-reliance on data and care plans, on assessment, support plans and reviews. Well, I would ask as politely as I could, why isn't the occupational therapist at the heart of those care plans, assessments and reviews? Why are they not in the centre of social care leading that process? Next slide, please. So there's a kind of a big question in England at present, and actually I work across the United Kingdom. The same question is being asked in different ways in Scotland, Wales and Northern Ireland as well. What is social care and what is its purpose? Everybody's looking, there's white papers, there's policy documents coming out of Wales, Scotland's got a big review going on. Everybody's looking at it. I've been arguing for about 20 years that the whole purpose of social care is to assist people to maximise their potential to achieve their greatest level of independence. This might just echo in the background, in the heads of occupational therapists. Next slide, please. The next slide work? So, generally, in my travels, in my visits to local authorities, I see OTs being used very well, assessing people for equipment, sometimes assistive technology, aids and adaptations. But that's what they do, become administrative managers of helping people get the right equipment. But I'm arguing that actually that so limits what the skills and the potential that we have and can have from the occupational therapy. I think, as I've just indicated, that OTs must be at the heart of any assessment of a person that approaches social care for help. Their skills and understanding of both the physical and mental challenges that people face, and how they might overcome these are absolutely critical to getting the best assessment and to help develop that support plan that's going to help maximise independence. One of the things I did about 3 or 4 years ago, was I went to visit a whole range of local authorities that told me they were introducing innovative practice. And one of the places I came to was actually the city where I live, strangely, in Coventry. And I discovered in Coventry, their kind of model was that every customer who approached the local authority for help from adult social care first had an assessment from a therapist, an occupational therapist. The occupational therapist worked with the customer to look at how their care needs can best be met. I should say Coventry has an infrastructure of voluntary and community organisations that kind of help people with advice and information on kind of other aspects of their care needs. But for people who needed care help, that everybody in Coventry get an assessment of how their needs were going to be met through an OT. And the council had contracts with 3 care providers whose role was to work with the occupational therapy and the customer to develop a set of plans together, a support plan, which focused on how, over the period of the next few weeks, they were going to help the person look at why they needed care and support and how they could help the person change aspects of their life in order to minimise their need for long-term care. Actually, how could they maximise their potential for maximising independence? And very interesting, this model was shown to me, and actually it means that about 2/3 of people who approach social care for help actually don't need long-term ongoing help. There are things that the therapists with their support workers working directly with people can help people achieve that aren't going to be achieved just by delivering them a care package, standard care package. Obviously, the 1/3 of people who have ongoing care needs are then assessed by social workers, but still the principle is we can still look to see how we maximise people's independence. And I think this is a really important aspect of that's missing in social care. A lot of my current work is based on working with people who are being discharged from hospital. Again, really interesting. I see so many reablement services, domiciliary care reablement services. There is no recovery going on. There's no reablement. There's no plan. People are thrown out of hospital into a system of care workers who are poorly trained, and there is very little engagement of OTs in the process. There is very clear research evidence that the best reablement happens when it's led by OTs. There's a little bit of research, just so you know, that also says that physios can play an important part in that too. But let's stay with the OTs because that's the message of today. So it's about allied health professionals being a really kind of important part. And in the best systems, every person who is going into a reablement program has a promoting independence plan, has a plan designed, written by an OT with the customer in order to support and direct the reablement worker as to the things they might do to help maximise the person, their potential. But as I've indicated, so many people, I was on a call with the Department of Health only yesterday, and they were saying all the poor hospital discharge systems have a common feature. There is no therapy supporting recovery, either in bedded facilities or in the community, or it's very, very poor where it does exist. Not poor because of the quality of the OTs, I hasten to add, is poor because actually the OTs are not put at the heart of this agenda. Now, I had better say this because I have, I'm not everybody always agrees with me. I'm quite used to that. And not all AHPs agree with this approach. And I certainly was working with one hospital group of AHPs in one setting, where actually my view was they were giving up on people too early. They weren't actually very keen on promoting independence for people at home, and they saw themselves as an assessment tool in the hospital. But my contention is you can't assess people for their long-term help in a hospital for all sorts of reasons, because of the state of the person, because they've been in hospital, pajama paralysis, all the things you understand. Actually, we need, I think the evidence suggests everybody has some potential for some recovery, may not be the level of recovery they had before. In fact, my last point is there is emerging work, which again I was talking to the Department of Health about yesterday, on the part that therapists can play in the recovery for people with dementia care, the kind of the Cinderella of all Cinderellas in the health and social care system. Next slide, please. So I think we need to really look at a different kind of social care system and of health and social care system, a different way, particularly the way we look at discharges. I've obviously been looking at outcomes for a long time, written about it. I'll give you a few references at the end of this. My concern has been that wherever anybody's tried to measure outcomes, they become complicated. In fact, if you Google, which I did just out of interest, all the tools that are available to help look at outcomes, there are, well, tens of them. I won't say hundreds. There probably are about 100 of them, different tools that will help, and particularly for therapists, particularly for allied health professionals. Loads of tools help you. I've been kind of quite interested in, well, how do you make this simple? Somebody's saying on this, it's not rocket science. No, I spend my career telling people the bleeding obvious. It's just only the rest of the world doesn't see that as being bleeding obvious. For me, there are actually some simple measures, and it's not to knock all the good systems that I've seen that therapists use, but of the simple system, I say actually the best measure in social care is, does the person need less help now, less health and care help as a result of our intervention? That's the simple measure. And does the person also think they've made progress towards achieving their goals? Actually, if we designed a system that was involved in focusing on promoting independence, and if we designed a system that actually had those very simple measures as being our currency for the whole system, not just about therapists, it's about why the whole system works, actually, I think we'd have a much better health and care system. And actually, interestingly and slightly ironically, we'd actually have a much lower cost system. Thank you.
Thank you so much, John. I can see that your email address is there, so I'm sure John won't mind people getting in touch. It's really hard to follow that, really. And I was just writing some notes down, really, and just sort of thinking about what John was saying, really. And there's something, isn't there, about changing the narrative. I mean, I'd be interested to know, for those on the call today after our last speaker, you know, how much does that occupational therapist at the front door, you know, how much of that model is more widespread? But also some really great pointers as well from John around, you know, what does, you know, if we've got to start somewhere with measuring outcomes, you know, does the person need less help in achieving the goals? You know, what does that look like in social care? So just to reflect on that and to keep on using the chat function to ask your questions. But I'm going to move on now to Chris, he's an occupational therapist in Bridgend, and he's going to talk about the wonderful work he's doing over there. Over to you, Chris.
Hello. Yeah, we had a little tech issue, so I'm going to get Lindsay to help me with some screen shares in just a minute. But yeah, just in a nutshell, so one of the things is we've actually developed our own outcome performance measure, just picking up on some of the things that's discussed, because we couldn't find anything it's a very subjective thing that we know we make a difference, but how do you quantify that and really evidence that? The bigger priority for us, though, was the fact that I manage the community OT service in Bridgend. We get about 1,800 to 2,000 referrals a year, very busy service, but going back about 4 years ago, we had about an 18-month waiting list. And so before we could even use data to look at outcome performance measures and measuring what difference we're actually making, the bigger issue is the fact that Mr. and Mrs. Jones were waiting so long for our service. So what I'll do is I'll go through some different charts and things and show you some of the ways that we've used data to actually impact and change our service. First thing is to say that the big principle we worked on is when it comes to, so if we can pull up the Excel sheets, the one with the, the PDF first, please, that is titled Caught Waiting Lists with Staffing Numbers, Lindsay. Thank you. So basically what we found is going back to kind of 2018, I don't know if you guys can see that, or if Lindsay, if you can zoom in a tiny bit. So basically what we had is we had a mess. I joined the team, so I was an OT in Bridgend and a senior OT, and then moved to a neighboring county for about 6 years, and then came back in July of 2019. So you can see kind of our waiting list trending there, where we had between sort of 400 and 500 people. If we can go to the Word document titled Community Occupational Service Update, Lindsay. So I won't go through all of this, but I'm happy to send this to you guys. In principle, what we said is Mr. and Mrs. Jones the individual doesn't really care about how many people are on the waiting list. They care about themselves fundamentally. And so it's like, if I go to Tesco, I don't care if there's 100 people or 5 people waiting in lines. I care about how long I'm going to wait. Fundamentally, when we go to the till, it's like if they have 20, tills open with 3 people in each till, and I don't care there's 60 people waiting. Most of us will go and we look for the shortest queue. So we took that principle and just said, actually, what we need to do is part of our quality, measuring quality of the service we're providing is the speed at which we're providing it. So we kind of broke it down and said the current resources we had on the previous chart, where we didn't have enough to address the problem. So I requested a meeting with our head of service and our director, and I put together this report that we'll kind of scan through now. So opening up with kind of the purpose of the report, if we scan down, Lindsay, I summarized kind of the background of how we got into the mess that we were in. If we keep going down, I summarized what the current situation was in regards to staffing. And if we go down to 3.2, and I'll hit on some of those figures because they're interesting there, slightly back up, there we go. So at the time of writing this in July 2018, what I said is 37% of incoming referrals were given a priority 1 status. They were allocated to a caught within 1 week. So we were dealing with the urgents, the manual handlings, people that were at risk, carers that were at risk, things like that. We were dealing with those. We then found ways of then siphoning things off. About 9% went to care and repair. 54% then were in priority 2 status. And then fundamentally our waiting list, we used to have priority 2 and 3, but by the time someone's waiting a certain period of time as a priority 3, they effectively become a priority 2 or 1 because of the time they've been waiting. So we switched to just having 2 different priority levels. And then our waiting list basically comprised of that 54% of the referrals. So if we scan down a bit, we broke it down by area for them so they could see. One of the things I like to say is that senior management, whether you're head of service, director, senior managers, they are not going to be very influenced by emotion. The team is stressed, we're struggling, those sorts of phrases, those sorts of feedbacks, because bottom line is everybody's stressed, everybody's struggling in different ways. Data is really what we used to change and to impact the situation we were in. So we highlighted how many referrals we get. So you see there in 3.3.4, during this kind of 6-month period of time, we were allocating and assessing about 594 people, but demand exceeded capacity by 197. So we basically were able to highlight that we get about 132 referrals on average a month, but 25% of that, the demand exceeded capacity, i.e. the waiting list was going to grow, and we were never going to address this problem at that rate. So if we scroll back down, we broke the waiting list down figures again even further to be able to show what our current waiting list was. How this is my Tesco example in 3.4. How long is Mr. and Mrs. Jones waiting? So they don't care about how many people are on the waiting list. They care how long they are going to wait. And then we went through saying, look, we're not just asking for more resources. We summarized the whole section 4. If we scan down, how we're looking at reducing the waiting times, disparity between networks, because we didn't want a postcode lottery where if you happen to be in one part of our county, you'd get seen 3 months before another part. That was one issue we did a lot of work around. Use of trusted assessors. I won't get into the detail of all this, but I can send it to you, or I'm happy to talk to people outside if you want more detail. We did a bit experiment about the front end and our kind of, the whole process mapping of how referrals are handled and can we streamline things. And I won't get into that. That was limited success, but did help us streamline things further. We then looked at reevaluating how we prioritize, and we put a community OT into housing that could deal with the follow-up queries and things that come back on DFGs. So once things are submitted and it needs OT input later on. So all things to kind of streamline how we were working. And then we looked at reducing the kind of rate of OT services that we're referring to COTS. So how can we actually enable other OTs? Look, instead of you recommending enablement, recognizing that someone's reached their maximum potential and they now need a stair lift, well, why are you referring to COT and then it's sitting on our waiting list for us to then look at the DFG and the housing adaptation side of it? Why can't we actually get you trained up on these bits to then just fill out a different form, recommend a stair lift, and then we can follow up the practical side of it later if we need to. But that delivers a quicker service. And as we all, well, as anybody who's been involved in waiting lists knows, a waiting list, especially the bigger it is, it generates its own workflow. It generates its own problems, its own kind of demands. So we made recommendations. And again, I'll kind of scan through this, but we basically said to meet the existing demand, this is what we have. If we scroll down, we needed admin support. And then to address the current waiting list, we then put together several options for our head of service and the director, and I went through those with them. And I'll skip the note at the end, but I kind of made a note of saying one thing you need to recognize is if you give us more OT resource, this is going to have a knock-on impact because we're going to see more people, we're going to order more equipment, so our equipment budget's suddenly going to spike. The housing, well, we're just going to pass some of these people on the queue onto DFGs, which means housing is going to see a bump, so just be aware. If we solve our problem, in one sense, it will create and pass some of that problem on elsewhere. So that's what we did. If we go to the Excel file called copy of COT waiting list, that one basically shows the impact of that from 2019 to current. We deal with, again, about 1,800 to 2,000 referrals a year. So we're a very busy department. My team is up to 12 now, including kind of OTAs and a bit of admin support. And we've taken a big chunk, which is kind of a slight miracle in itself, is the fact that we put together this report and we got more resource and we got more OTs. We got more kind of what we needed invested in our service just prior to COVID. So we're probably one of the few departments and services that's actually managed to improve during the COVID, time, which is that was just purely chance and luck that we'd been working on this. You'll see a spike right there at the end. The last time I updated this chart was end of December 2021. Over the last kind of 2 months, 2.5 months now, that has come back down again. So we're effectively getting in back to the original data. We're effectively getting in the same number of referrals as we allocate and deal with in a week. So we effectively have a nil waiting list, but practically that's about a 2 to 3 week waiting list because of just the volumes we get through and the turnover. So the number of people that sit on the waiting list within sort of 2 to 3 weeks, our priority twos are allocated, and then within days, the priority ones are. What I thought I'd show just quickly before I finish, and then we can do questions later, is thank you. You anticipated the last one. So if we can zoom in, this is the data behind those pretty graphs. It's fairly easy to, it takes time, but it's fairly straightforward and easy to formulate this. We basically look at referrals. How many do we get incoming per network, and then total allocations? How many do we deal with each month in each network, and then total? How many do we then, if we scroll down to the bottom, how many do we then siphon off for telecare or for MAP? It's one of our given things to care and repair, where we say, look, if someone needs rails, we don't necessarily think about adaptations without delay. In a piece of work that was done a few years ago, we said, look, we don't need to have OTs assessing for rails. If someone is feeling unstable on steps or something, actually, irrespective of whether or not an OT would say, well, they have this and that functional problem, if they're feeling like they're going to fall or they're feeling uncomfortable on the steps, let's give them a rail, if that's preventative, if that's potentially preventing things. So we push all that over to trusted assessors and just say, just give them a rail, and our budget pays for that. And we put that under the preventative. So in the number waiting over 8 weeks and the number waiting over 4 weeks, if we just scroll down a tiny more, I'm not sure if the 4 weeks is showing for some reason. And then if we scroll to the right, there we go. We added in 4 weeks at that point because 4 weeks was never even a consideration for us because we had such a bad waiting list. We talked in months rather than weeks. So you can see the numbers reflect those charts. This is the data which produced the charts, which then enabled us to summarize what our service was doing well, where we were failing. And in America, I grew up in America, but moved here about 20 years ago. We have something, and I apologize for the crassness of it, but we have something called a CYA policy, and it's cover your own backside. So we knew we were getting complaints about our service, and rightly so. We were not providing a timely service to people. And so what we said is, we can turn the slides off now. What we said is we need to be aware that the heads of service, senior management, they need to have the data. They need to have the information to know you're going to continue getting complaints about the quality of the service. Once people see us, we were being rated and coming back with feedback as providing an exceptional and a very high quality service. The problem everybody had was with the time they waited for that, which is why we talked about this Tesco example or Asda or whatever your local superstore is. I don't care how many tills you have open. I don't care how many people you have waiting. I care how long I'm going to be standing to purchase my shopping. And fundamentally, that same principle. We used all this data. We got the investment. We improved things. We didn't just ask for finance. We actually looked at changing a lot of things. We have changed. And that's probably a good practical example of in practice how we've used data to really impact the service and also to provide a better quality service. The bottom line is Mr. and Mrs. Jones are the people that matter. And that's kind of our case study and example of using data in practice.
Thank you so much, Chris. That's absolutely brilliant. And we've still got 8 minutes as well. So what I'd really like to do is just invite people to either put their hands up or to pop something in the chat. But, be brave. If you want to unmic yourself and ask Chris, John, myself or Mark a question. We've obviously covered a great deal. We've covered the survey. We've covered that sort of digital skills gap. We've talked about outcomes and social care in the direction and occupational therapists at the heart and front door. And then Chris has just given us a brilliant example as well about demanding capacity, but in a really, really easy, user-friendly way. I can see that Angela thinks this is brilliant evidence. So Chris has got his hand up. Is he going to ask himself a question?
Fine. I was just going to, I think it's easier to answer Angela's question directly because other people might have the same. We're currently in the middle of piloting our outcome performance measure. So rather than sharing it now, it's basically in a bit of a rough form. So it's basically in a bit of a, we've combined some kind of established outcome performance measures with, well, hang on, that's more hospital based, that's more hospital focused. We need things that are more community based and community focused, and recognizing, well, actually that doesn't really account for this aspect where we might have spent money on someone and specifically data wise proving, well, we might have saved money on care, but actually the data shows that we perhaps didn't make an impact financially. So you take someone where you say we actually spent money on them, we enabled their independence, and especially with preventative things, it's nigh on impossible to be able to use to get an outcome performance measure that reflects the preventative side of things, which is what we want to be doing. So we're looking at trying to find a way to combine those things with kind of case studies and examples of people being able to say, well, this is the impact it made, but how do you quantify the fact that you're potentially preventing people from having that fall, which requires the hip replacement, which then requires the reablement, which then requires all of these things. Well, that's kind of what we're working on, but it's very early doors. The bigger problem for us was get the waiting list down, and because we've only done that in the last couple of months, my next kind of big project is this outcome performance measure. So I wouldn't share anything yet because it's still very early, but maybe one for 6 months from now, or when we've worked on it a bit more.
Thank you, Chris. And John?
I was just going to say that there is a very excellent research study looking at how you prevent falls. So have a look at that. It's very clear that actually you can't prevent the first fall. What you can prevent is subsequent falls. paraphrasing, obviously quite complex research. So the way in which you respond to someone who's had a fall is absolutely critical to the risk factors as to whether or not they'll have another fall. But you need to look at the research. Google it. It's probably as strong a research about prevention as there ever has been.
Thank you, John. If you've got access to that and want to pop that in the chat, that'd be wonderful. But I
don't have access to it as I'm sitting here, but I can send it to you. And it's I only got to Google. That's what I'm going to do.
Brilliant. And I guess in a way that's what I was, I think Chris's example of actually around that grab word, people feel like they do, if they feel unconfident, just give it to them. I think that that's probably the best measure of that preventative thing, really, isn't it? Let's not wait for them to fall off that step. If they feel unsafe, put it in there and do it quick. Any questions? It's been very quiet on the chat. I can see Susanna is talking about she's in the third sector organisation. It's quite a long message there, so do take a look at that, but she's specifically asking around outcome measures, and I think that's really significant. Because in social care, obviously, there's a lot of sort of commission services, third sector organisations you work with, and I think for those, what kind of outcome measures would you be sort of looking for in terms of those commission services? Probably not paraphrasing that as well as John did a minute ago about the research, but take a look at that thread. Anybody else? It doesn't seem so. So I guess it's up to me then to conclude the session. And I guess probably this gives me a few minutes, which I wasn't expecting, to actually talk about what RCOT are planning to do over the next sort of 18 months. So as I started this sort of presentation, we now have a brand new data and innovation strategy, and we've got the beginnings of some survey findings, but also sessions like this as well, to sort of try and really hone down to what really happens next. And I think there are two main issues really. There's something around improving occupational therapists' confidence in being able to evidence the value that they bring. And I suppose just thinking about our overarching RCOT vision, which is that people everywhere value the life-changing power of occupational therapy. And I think there are two things there. There's something about the quality of what they receive when they get through that front door, but I also think there's something as well, which Chris has raised a really important issue, is actually about getting it quickly before things deteriorate, escalate, and over-reliance on services where they can't get that back. And I think probably every occupational therapist on this call has got examples in their head of people that waited too long, and actually they could have got something quicker and maybe more independent sooner. So I think that in terms of the strategy and thinking about data and innovation, it's about looking at particular areas, and certainly for me, I'll be looking over the next 18 months to really sort of focus at different contexts of practice and understanding their issues. So I'd like to see particularly a focus on social care outcomes. What outcomes do we need to start thinking about that will evidence the value, as well as the capacity and demand stuff. And then there's something about supporting occupational therapists to work more efficiently with systems as well. You have my email address, it was just on the slide. Please get in touch with me. And also please share this recording as well. It will go on the Faculty of Clinical Informatics web pages, and we'll shortly make it over onto our RCOT Informatics and Digital Technologies page. So please do share. But I'd just like to thank the panel for their excellent presentations today, and thank you for everyone attending.
Thanks, Suzy. Thanks to all of our speakers today for such an excellent session. Lorenza's put in the chat our feedback form as well. If you have just 2 minutes to fill that in now, we'd really appreciate any thoughts you've got on the session today. And thanks everyone again for attending.